doing this. Welcome everybody to Support Group. Once again, we've got a very distinguished speaker who's giving a presentation. This month it is our very own Associate Professor Ewan Miller, who does all your breast pathology, or most of it, if you have surgery at St George or St George Private, and he's very kindly offered to speak once again on breast cancer pathology. So, Ewan, thank you so much for giving up your time and particularly for preparing these slides in your presentation while you've been on leave. So we really do appreciate your expertise and your generosity. Thank you.
Not a problem. Thank you. Thanks for the kind introduction, Moira. So, yeah, no, it's a pleasure to come back and talk to you all again after last year. So just unfortunately, we couldn't meet up in person again. But so just outline what I'm going to talk about. It's basically just the basics of what I do and what pathology involves on a sort of day-to-day basis and why it's important. As you know, you will all know what your pathology report looks like, but just sort of the amount of detail and the amount of work that goes into generating all the reports that we push out every year. So there are a lot of them. So we have a department of about 7 and a bit pathologists. Some work full-time, part-time, and we deal with about 16,500 biopsies a year. Now, when I say that's a number, that's cases. Now, each case can vary in size from one little piece of tiny tissue from someone's stomach up to a big bucket which contains bits of liver, colon, and all the rest of it. So there's a huge variety in numbers, but in one case can have as many as 1 samples, or, you know, prostate cores, which are like 25 biopsies, and that counts as 1 biopsy. So it's a big amount of work to get through. So we're in the business of diagnosing breast diseases, and not all of it is cancer. There are a lot of lumps and bumps you get in the breast which have to be investigated, and the basis of that is what's known as the triple test, which is the combination of clinical examination, feeling for lumps and bumps and nipple discharges, things like that, discoloration, some sort of imaging, which is usually ultrasound and mammography, but more recently you've got MRI. Moving into the frame as well, and PET scans and things like that. And obviously what we're talking about today, which is pathology, you've got to get a needle into the lesion of interest and find out exactly what it is. So one of the main areas we work with is in breast screening pathology. So breast screening, as you know, has been around since well, where I come from, which is Edinburgh in Scotland, which is one of the first breast cancer screening services that was set up in the world back in 1976. So I grew up with a background of a lot of breast pathology in my training. So it's been a very successful program, and it's been able to reduce significantly the mortality from breast cancer over the last 30 years with a 15% reduction due to the, of course, early detection of abnormalities. So the main things that you pick up in mammography, apart from sort of these well-defined opaque lesions or mass lesions, which can be anything benign or malignant, there are other regions of microcalcification which produce little stones in the breast, and these are the things that are biopsied. So in terms of trying to understand what different diseases in the breast look like, this is just a simple diagram which kind of outlines the sort of ductal system of the breast. So you've got to think is that specialized gland which starts off at the periphery away from the nipple, where the glands which produce milk are located, and then they drain into sort of increasing size of these larger ductal structures which open out onto the nipple. So if you cut these in cross section, they're basically a series of tubular structures lined by cells. And as you progress from sort of normal down sort of atypical changes and proliferative changes, which eventually end up producing cancer, you get this filling in of the ductal space. And once it's become sort of fully blown and quite abnormal, you end up with ductal carcinoma in situ, which is this sort of area here where you've got filling. Can you see my mouse on the screen, by the way? Oh, you can. Good. Yeah. So you get this piling up of cells in the middle. Now, this can come in various shapes and sizes and severities, but essentially it's malignancy at its very earliest stages, but it's a type of malignancy that can be cured because it hasn't actually spread out of the ductal system and into the adjacent breast tissue. So essentially, with good surgical treatment and radiotherapy, you can effectively reduce the incidence of the disease coming back and any possibility of invasion. So invasion tends to happen if this is left, over a period of time. People have followed these things up, and it usually takes, possibly in the region of 10 to 15 or maybe even 20 years for these things to actually grow and proliferate. And then eventually, when they become invasive, these little cells start to invade out the edge of the duct. And that's what invasive cancer is, or as we call it, invasive ductal cancer, which is the most common type. So again, just to show you more simplistically, again, there's these inner lining cells which you have in DCIS, and once it becomes sort of accumulates more abnormalities in the DNA, the tumor cells lose the sort of ability to stay confined inside the ducts, and they spread out into the breast tissue itself. So in terms of what DCIS can look like, these are core biopsies from mammography, and you can see these little pale specks, which is actually areas of microcalcification, which the radiologist can usually tell if they think they're worried or whether they think it's benign. And these are the areas that they'll target with these core biopsies, or even larger things called mammatomes, which take out these big chunks of 2 or 3 centimeters. And the areas in that last image there, which correspond to those pale bits, are these purple chunks, which are areas of calcification. And this is caused by dead tumor cells, which when they die, they calcify. So that's one of the sort of features that we can actually use to detect cancer when it's very earliest stages. So this is just an example here of what ductal carcinoma in situ looks like. But we'll come back to that. That was just to talk about mammography. So in terms of making a tissue diagnosis, there's 2 ways you can do it. You can do it sort of very quickly using a fine needle aspiration biopsy, or you can do it with a core biopsy, which takes a little sliver of tissue. Fine needle aspiration uses a little skinny needle about the same size as you use for taking blood, and you can suck out cells and then spread it quickly onto a glass slide, stain it up with some blue colored dye, and you can look at it very quickly. So this is something that we used to do quite regularly in the breast screening assessment clinics, where we'd actually go down and give diagnostic reports actually when the patients were on site, and get back to the surgeon within an hour or 2. But that's kind of all died away now, and people want core biopsies because they want other things done with the tissue. So in fact, FNA is actually pretty much died out in breast pathology now. It's all done by core biopsy. So it's all a kind of thing of the past, really. We hardly see any, which is weird, because when I was training, I used to do 5 or 6 every day of the week. Now I see about one a year maybe. So it's all changed. So core biopsy takes a bigger sample of tissue. It allows you to do things you can't do on an FNA, like look at the architecture of the tissue and actually make a distinction between DCIS and invasive cancer, which you can't do on a cytology specimen. And the other thing you can do as well is you can look for biomarkers like estrogen and progesterone receptors, which again you can't do using the fine needle biopsy approach. So it gets a lot more tissue, and we can process these pretty quickly as well now. So we can usually get these out within 24 hours of the biopsy occurring, which is what we do now for the breast screen patients. So in terms of then providing, all the information that we do, and I'm going to go back into this a little bit more detail, the surgeon really wants, once he's got the core biopsy results, to do some sort of definitive surgery, which is either going to be a local lumpectomy with some sampling of axillary nodes to look for early spread, or if needed, a mastectomy for bigger tumors or multifocal tumors. So 1, 2, 3, 4 lesions maybe, or maybe 1 lesion, which is larger. Or sometimes, the patient prefers really to have a mastectomy, which is totally understandable. So that's the surgical side of it. And then once you've taken the lump out, and again, something which we do frequently is to look at the axillary lymph nodes, usually at the time of the operation. And this is really to pick up the earliest possible signs of spread of an invasive tumor to what is the lowest lymph node in the chain of lymph nodes in the axilla, which is where the tumor cells might locate to. So using an injection of blue dye and radioactive tracer, which is done a few hours before the operation, that gives the tracer time to go through these little lymphatic channels and locate in and around lymph nodes which are close to the tumor. So when the surgeon is doing the operation, he can use a little probe which picks up hotspots. And also, when he's dissecting through the fat, he can actually see the blue dye tracing through the tissue, and he can locate with almost pinpoint accuracy the position of the sentinel node. And sometimes they will take out 2 or 3 of these nodes and send them to us at the time of the operation. And we look at these very quickly using a special freezing technique called a frozen section. And we can try and see if there's any evidence of spread, and then if there is, whether the surgeon needs to go on and sample more lymph nodes. Now, usually most of them are negative, and the surgeon will leave the rest of the axilla alone and prevent things like lymphedema from a full axillary dissection, which is really, it's almost a thing of the past. The rates, I think, have dropped significantly because of this less invasive surgery. So it's all good for the patients, I think. And then taking all of that information, there's a lot of big treatment decisions which go on at the multidisciplinary team meeting, which is held every 2 weeks. Everybody who has a new diagnosis of breast cancer gets a discussion. And this is where all the planning goes on. I'm sure Gina would have told you about this a couple of weeks ago. So they discuss, you know, who needs adjuvant hormone treatment, who needs chemo, who needs radiotherapy, and who needs more surgery, of course. So this is all planned, but all of these decisions require the pathology report. You can't make treatment decisions without the pathology report because it contains all of this information. So that's basically what we do. So the MDT can be a bit of a bun fight sometimes.
Really good picture for tonight.
Yeah, so he could be running the show again, which is a wee bit scary. But fortunately, everybody at our MDT is very friendly. So sometimes there's some frank discussion, but it's all to get the best things and differences of opinion all ironed out. So there's usually, you know, upwards of, 20 people with pathologists, different oncologists, radiation oncologists, medical oncologists, several surgeons, radiologists, genetic counselors, nurses, social workers, and all sorts of people who are involved in care. So it's a great opportunity to learn about breast cancer as well. So there's a lot of students come along and we go through all the cases and discuss the problems. So it happens every 2 weeks. So once you've got a diagnosis and you have your surgery, which most of you have been through, then we end up with all these buckets and biopsy pots of different sizes, and they all contain different types of specimens, and they all have to be sorted, booked in, and given a specific number. Now, for most people, usually what happens is you have a lumpectomy, which basically means you're cutting out the tumor. So in this little picture here, these are all real specimens, by the way, they're not photoshopped or anything. There's a tumor in the middle here outlined with the arrows. It's basically been cut in half. And then around the outside, we've got the fatty tissue, because you want to get the tumor out with a margin of normal fat, so it reduces the risk of recurrence. And then before we cut the specimens up, we paint these different colored inks on so we can actually see how far the tumor is from the edge of the specimen, and we measure it in 6 or 7 different dimensions, a pretty, very fine detail down to fractions of a millimeter in some cases where they're close. And that helps guide the surgeon as to whether he wants to go back and do some more excision. So once we've taken the blocks, this is one of our registrars who's chopping up at the bench here. It's very busy at the moment because it's the sort of lead up to Christmas. We take lots of blocks, usually from an average case, which would be any of up to about 30 of these little brown cassettes. Each piece has got a little bit of tissue in it, and you can see the colored inks there on the side. And then once they're put into these little brown cassettes, each of which have got your name and a specific identifying number on it so they don't get mixed up, we know exactly where they're from. And each block gets a description, so we know exactly where each piece of tissue has come from in that specimen, so you can reconstruct basically a map of what's happening in the tissue. So you can do it with a lot of detail and a lot of precision, which is what you need. So all of these pieces of tissue are then placed into these machines, and they're processed overnight through a series of alcohols and other nasty chemicals, which basically take all the water out of the tissue and then replace it with wax. And what that does is it makes it hard enough to actually cut a section, which I'll show you in a minute. This is just another example here of another breast tumor, which again has been sectioned, almost like a loaf of bread. And you can see here we've got a pale tumor in here. So again, that would be sampled and sections taken. Another thing that we often do as well is we x-ray the specimens to look for calcification. And once the specimen's been x-rayed and we cut the specimen into slices, we often x-ray those again. And then we use that as a template to actually mark on here which bits of the tissue we're interested in, so that when we get the tissue sections, we can go back to the original x-ray and say, well, this is from this particular block, slice 3 here, and right up at the top, it's close to margin and so on. So it's a fairly labor-intensive process. So once the bits of tissue have been processed overnight, that takes about 12 hours in a machine. We get a piece of tissue that comes out, which is placed in wax and chilled, and then the wax solidifies and gives you this hard piece of tissue that you can actually cut. So this thing here, this is a microtome, which cuts these wafer-thin sections, which are half the thickness of a red blood cell, which is incredibly thin. So that means you can actually see the detail and the structure of the tumor very easily. So that's cut, and then they're picked up on a glass slide down here in the bottom left, and then they're run through this series of funny colored dyes. A lot of these are derived from different plants over about 150 years ago. So that technique hasn't actually changed, and it gives you a sort of pink and blue stain of section. So this is the original guy who invented, or one of the original inventors of the microscope, Anthony van Leeuwenhoek, who was a Dutch, well, he wasn't really a pathologist, he was just really a scientist, because they didn't really know much about pathology then. But he invented the first microscope. But things have kind of changed since then. We've kind of got a bit more high tech. And there's lots of fancy tricks that we can do. So this is my office, and you can see I've got this.
You don't look the same as he does.
Yeah, the clothes have changed a little bit, but so this microscope is probably about $20,000 worth of equipment, and it provides very high power images. And I've got lots of different lenses on the end here. So this changes the magnification, so you can go from very low power, or ×2 as we'd call it, right up to about ×400. So you can magnify what you can see by 400 times, and that's really the power of what we need to do our job, basically. So you can see my room there, there's piles of slides that just gets cleared off every day, and then the next morning somebody comes along and replaces it with new cases. So it doesn't really stop. It's a bit of a machine. It just keeps going and going every day. So lots of slides. You can see them all laid out in trays there on my desk. But one of the areas of something new that I was going to mention is the area of artificial intelligence, which is sort of creeping into pathology now. And there's lots of these sort of, you might have heard about them in Google, saying that they can replace radiologists. Well, it's now sort of coming into pathology and saying that, you know, they can train these machines who can recognize patterns, and they're, you know, better than pathologists can do it and all the rest of it. So, you know, I don't think so, really. I mean, these are all written by people who are trying to make money because they want to create new companies. So there's a lot of hype out there. I mean, artificial intelligence is going to come into pathology, and it's going to almost be like an assistant. So I can get the machine to check things that I've done and maybe review, you know, 60 slides in 5 minutes for me, and just to double check I haven't missed anything. But it can't do what humans can do, no question. So it can't take things that I've read about in a book, and I might think, you know, I might put 2 and 2 together and say, oh, this is funny, I haven't seen this before, but I think it might be this rare variant of cancer. Now, a machine can't do that. A machine can only do what you can train it to do with examples of what you give it. So it can get very good at picking up and identifying things that you train it on, but it can't identify things that it hasn't seen. So it can't do that. Well, not yet anyway, maybe in 50 years, but there will be bits of it creeping in. So the things you can think about are things that look like things that we as humans can tell are not the same, but a machine would have difficulty. So this is the same for morphology and tumors. So you could, you know, show it something which might be completely wrong, and it might say this is a type of breast cancer, where in fact it's something completely different, and the machine would not have a clue. So it's easy to tell the difference between, you know, a big shaggy sheepdog and a mop, but you know, an artificial intelligence algorithm, you know, it's white stringy things, you know, it just looks like it's the same. Or is it an owl's head, or is it an apple, or deep fried chicken, or labradoodle? So the same applies to any image. There are mimickers. Okay, so that's where you need to have a human to stay in control of the machine. So some machines are good, but they've got to be heavily supervised. And then you're going to have problems, of course. If you let the machines do it all, then when it goes wrong, somebody's going to get in trouble. And who's going to take the responsibility? So these are some of the things that are, because this is going to happen, these are going to be the problems that are going to creep into, this is going to be the whole of medicine, because this is going to be affecting everything that happens in medicine, because there's so much information in there now that the doctors who are trying to do this by hand are getting swamped with information overload. So it's the tip of the iceberg, and there's a lot of research on this at the moment. So watch out. So in terms of, numbers of different types of breast cancer, this is the current classification. There's about 26 different types of breast cancer, and there are variants of all these 26 types. So in order to train a machine, you'd have to give them thousands of examples of every type, okay? So that's going to take a long time, and it needs to be tested. So just to let you see what it looks like, I mean, these are the sort of garden variety types of breast cancer, which is known as invasive ductal cancer, which is the most common. That's about 3/4. About 10% of cases are known as invasive lobular cancer, which is this picture down here, which has got a different appearance, where the cells are more singly infiltrating rather than big groups and nests of cells. And then apart from those two, there's the special types of cancer, which are usually lower grade lesions, which are sometimes known as tubular cancers or mucinous cancer, which are lower grade and usually ER positive and usually do very well. So most types of cancer, about 80%, usually express estrogen receptors, and then there are other ones which don't. But all of these tumors here, these are all different types of estrogen positive breast cancer. And I'm sure even you guys, although you're not pathologists, you can all look at that and say, well, they all look incredibly different. And they are. And these are not all just from separate patients, but sometimes you can have all of these 4 appearances in one tumor. So the heterogeneity and the mixing up of types is something which is a problem in terms of treatment, because each of these 4 different areas can respond differently. And this is one reason why tumors don't always respond to treatment, because there are always little bits of the tumor which are totally different from the bits that do respond. So that's something which is going to be ongoing, and it is an ongoing area of active research to help reduce recurrence. So some of the features, as you would know, that we use to treat breast cancer, apart from the histological type, is the tumor size, the grade, the presence of lymphatic invasion, which are these little drainage channels around the site of the tumor, which lead into the lymph nodes, whether you've got positive lymph nodes or not, the age of the patient, whether you're premenopausal, postmenopausal, and then ultimately the presence of biomarkers, which are these biological features of estrogen, progesterone, HER2. So this stain here is what the HER2 protein looks like. It gives you this dark brown stain. And it's different to the estrogen receptor, which gives you these brown blobs in the nucleus. So again, we do all of that after we've looked at the original pathology. That's just a higher power. And these results get added on a few days after the main pathology report has gone out to the surgeon. So these are the things that the oncologists are wanting to know about, because that will determine who gets hormone therapy, chemotherapy, or other drugs like Herceptin. So one of the sort of less common types of breast cancer is a thing called triple negative breast cancer, which I think somebody had asked about. So this is the type of tumor which doesn't express estrogen, progesterone, or HER2. It's completely negative. It often has quite a distinctive appearance down the microscope. It's usually got a lot of tumor infiltrating lymphocytes, and has often got this sort of very undifferentiated appearance where there's just lots of cells, and it often grows quite quickly as well. So this stain here is just an estrogen receptor stain, which is completely negative. So these, again, even within that subtype of tumors, there are varieties and there are different types as always. So there are sort of ones that we associate with less of a risk of recurrence, which are these metaplastic cancers here, but there are also metaplastic cancers which have got a higher risk of recurrence. And then in the middle, we've got this sort of run-of-the-mill type of triple negative cancers. So just saying it's triple negative doesn't really mean a whole lot, because again, you've got to specify, well, what type of triple negative cancer is it? So again, that's all done by the pathology. And it's important to get that information, because some people who've got slightly higher risk features will need to have chemotherapy if you're triple negative, but some triple negative cancers just need to be excised, possibly with radiotherapy, and don't need chemotherapy. So it's sort of a confusing array, but it's just part of the problems of all types of tumors, and not just in breast. this happens all over the body. There's so many different varieties, and they're all different. So another variety of cancer, I think somebody had asked about as well, was inflammatory breast cancer. So this tends to be more associated with a more locally advanced tumor, which can often be mistaken for infection and inflammation in the breast, because it often produces this red appearance. And that's why it's known as inflammatory breast cancer, because a lot of people can misdiagnose it as being mastitis or some sort of infection. And some people, if you're not aware of it as well, if you're a patient, you would think, oh, it just feels hot red, and you would delay going to see your doctor, quite understandably. And sometimes even GPs can think it's an infection and put people on antibiotics until, it doesn't go away and it tends to progress. So the reason it gets becomes quite red is because, in fact, there's a lot of tumor in this picture down here at the bottom. These little spaces are actually been infiltrated by, these are lymphatic spaces infiltrated by tumor, and it tends to block the lymphatic drainage out of the breast. So it tends to sort of dam back up and causes this congestion and reddening in the breast. So it's not very common, so we see a few of these every year, but it does cause some diagnostic difficulties and can cause a delay in diagnosis. So most people, when they come in and they've had their pathology done and discussed at the MDT meeting, so they would have had surgery first and then go on to have adjuvant treatment, which is either chemotherapy or hormonal therapy. So that's the kind of standard adjuvant pathway. But some of you, I don't know if any of you have had this, but the other approach, and which is coming in more prominently now, especially for triple negative and HER2 positive breast cancers, is to have neoadjuvant treatment, which is where you have treatment before your surgery. Now, what that allows you to do is, when you get your diagnosis, then you get started on treatment, you can actually observe how the tumor responds to treatment. So by the time you have the surgery, whether that's in 2 or 3 weeks or 2 or 3 months or 6 months, when you have the surgery and then you examine the tumor, you can actually see how well it's responded to treatment. So it gives the oncologist a lot of information about what to do next. So this is actually, it's proving increasingly popular because of the extra information it provides. So for triple negatives and HER2 positives now, it's becoming very common. So we're seeing increased numbers of these cases coming through. So that kind of leads into some of the other newer things that we're doing as well. So one of the studies which we started a couple of years ago was to actually do this sort of approach, but in people who've got, sorry, my voice is just drying up here. I was just have a quick, oh dear, sorry, losing my throat. I've got a bit of a cough. I haven't got COVID or anything. But, so we started this study a couple of years ago where we're offering this sort of approach to women who have ER positive breast cancer and who are postmenopausal. So what we've been doing is most of the ladies who come through breast screen get put onto the study. And what they do is, at the time of diagnosis, we start them on the same day. They are diagnosed on a drug called an aromatase inhibitor drug called anastrozole. Well, there's another one called letrozole, or Femara is another name for it. And they stay on the drug for the time that they're waiting for their operation. So that can be as little as 7 days or 2 weeks. And what we can do then is, when the tumor is excised, we can compare the lump when it's been excised with what happened before treatment. And that can give us information about how well the patient's tumor is responding to hormone therapy. So we've turned this into a little research study. And the other things that we're collecting, apart from the tumor tissues, we take bloods as well. And we're also collecting microbiome samples, which I'll mention in a minute. So we get poo samples and we get oral swab samples from the patients before and after treatment. And then we're doing a comparative study to look and see what's actually changing before treatment and after treatment at 1 to 2 weeks. So this gives us information. Even in a short time frame of 7 days, you can actually see quite dramatic differences. So this is to give you an example here. So this pink and blue picture here is a picture of the tumor before treatment. And if you put on the special stain here, which gives you these little brown dots, this tells you how many of the cancer cells are actually dividing. So that's a sort of baseline level. And when you put the patient on the drug for 1 to 2 weeks, lots of these brown dots, if you respond, they disappear because it's turning off the proliferation in the tumor, which is what we want to see. But for those patients who don't respond, we tend to see a similar number of brown dots, which means your tumor is still growing. Okay. Now, most people, fortunately, this is just a little graph here to show you on the left-hand side. This is where people are starting off. And then on the right-hand side, you can see there's a slope down because everybody's tumors are basically showing that there is some sort of effect on the tumor, which is good news. Most people tend to switch the tumor off pretty substantially, but there's a few people, about 10% of cases, who don't switch it off enough. So those ones are where the tumor is still dividing, even when the patient is taking the treatment, which is not what we want to see. So this lets the oncologist know which patients potentially will need extra treatment, but they get this information within 1 or 2 weeks of starting treatment. So it used to be, you know, previously you would be put on treatment, you know, and you wouldn't really know. You'd go away for 5, 10 years and not know if your endocrine treatment was actually having any effect on the tumor. But now we can look and we can get this information at 1 to 2 weeks. So just to give you an example, this is a bigger trial from the UK that did the same thing. So this is just a graph of people who had recurrences at 5 years. And if you're on the good end here, sorry, where your tumor stopped proliferating, you can see here that you've got a very low risk of recurrence. So 95, 96% of people didn't have any evidence of disease coming back. But if your tumor stayed proliferating here, that drops down to about 80%. So at 5 years, about 20% of people had evidence of a return of disease. So these are things that you can then look for and you can predict, you know, 5 years earlier. We now know that if your tumor is still dividing on this treatment, that you really need to be given something else. Now that either means whether you need to go on chemotherapy or change to a different type of endocrine therapy. That's up to the oncologist, but it's giving them extra information. So we think it's quite useful. So we're going to keep going with this study. We've got about, I think, another 3 or 4 years to go. So this is my last slide. So this was just to let you know about the microbiome as well and why it's of interest, not just in breast cancer, it's of interest in virtually every disease under the sun. So you might know that there's a big microbiome research center that's opened up at the hospital. That opened up about 3 years ago. It was actually opened up by another Scotsman who happened to be at university with me at the same time, although I didn't actually know him. So Professor Elomar is from Glasgow University. So that's where I trained as well. So we've got friends in common, but he moved out here 3 years ago and he's a world expert in the microbiome. He's a gastroenterologist. So when we started up our study, we went to speak to Professor Elomar and we talked about, you know, how we could do a study on the microbiome. So the way that the microbiome is thought to be important is there's a lot of influence over different diseases, but in terms of what it does potentially in breast cancer is it's involved in metabolizing estrogen in your body. So these trillions and trillions of bacteria which are in your gut and weigh about 2 kilograms, they've all got lots of different activities in terms of things that they can do and produce different chemical messengers. But part of the thing that they do normally is they're involved in the metabolism of estrogen in your body, because when estrogen is excreted, it goes out in your bile and your urine. And when it goes into your bile goes into your duodenum and out through into your poo, and then it's excreted in your poo. But some of the bacteria in your gut can metabolize the estrogen as it's being excreted, and then some of it gets reabsorbed while it's still in your intestines and goes back into your bloodstream. So there's a lot of interest into why that happens and what type of bugs might increase or reduce that reabsorption process into your blood. Because you can imagine this could affect your estrogen levels in your blood depending on what type of bacteria you have. So that's a big area of active research at the moment. But at the moment, it's only really an association. Nobody really knows how important it is, because the number of things that can affect what's in your microbiome. You can see down in the bottom left here, there's, you know, what type of diet you eat, what your body mass index is. That's an important one. Types of drugs that you're actually taking as well, what your ethnicity is, which part of the world you come from, what your family history is, what other things you take in your diet, what sort of foods you eat. So there's so many different factors involved in determining what type of bugs you have inside your intestines and different parts of your body, that it's actually very difficult to prove exactly which is the bug of interest. So there's a lot of activity going on this at the moment, and we're sort of looking into this at the moment. So that's one thing about the microbiome. So that's your gut. But the other thing which is interesting and is only just starting to appear in the literature at the moment is the fact that there also seems to be evidence of bugs actually being alive and kicking in your breast tissue. So this is sort of news. There was a big study which came out in a very big journal in the last 6 months, which actually showed that these organisms seem to be in not only in your breast tissue, but they're actually in the breast tumors as well. Now, nobody again knows quite how important this is, but potentially because microbes can interfere with how your immune system works, there's a lot of interest to see, well, if they're possibly controlling how your immune system works, then maybe we can modify the bugs to modify your immune system to get the immune system to recognize cancer. So this is a big area of interest in a drug treatment called immunotherapy, which has been around for the last few years and is kind of big in lung cancer and melanoma, but it's also now being used to treat metastatic triple negative breast cancer. So there is evidence to say that if you modify and play around with the gut bacteria, you can actually change the way patients respond to immunotherapy, which is a pretty fantastic development. So a lot of this has been done in animals, but they're now starting to do this in humans. And you can do things like you can actually do transplants of fecal material into different recipients to change the way they respond to different drugs. And this has been done in different types of diseases as well. And in things like inflammatory bowel disease and different bowel infections, you can actually take a poo sample and give someone else your microbiome, and you can actually treat the inflammation in the gut by doing that. So it's going to be an ongoing area which is going to expand pretty rapidly. It's already red hot, and there's a lot going on locally in your area. So it's another area I just wanted to flag to you. You've probably heard a lot about it because there's adverts on the TV about my microbiome and send your poo sample off to Queensland to get it done and all the rest of it. So it's certainly very interesting, but a lot of it is, there's a lot of hype out there as well about it. You know, it's going to be the next cure for everything, but to be honest, it's very early to say, and everybody gets very excited early on, and then, you know, everybody will cool off once we've got a bit more information. But it's certainly interesting, and we're getting involved in trying to work out what exactly it means in breast cancer. So I'll just finish there, and if you've got any questions, I'll be happy to try and answer them for you.
That's fascinating. I've heard a lot about that, microbiomes, but I've never even thought of it being related somehow to a breast tissue sample.
Yeah, absolutely.
You forget that things from your guts can affect your whole body. That's amazing.
Yeah, well, it's interesting because another thing that people don't realize as well, that when you talk about your immune system, that 80% of your immune system is actually in your gut. So all the way from your mouth down to your bottom, there's lymphoid tissue all the way down, and everything that you eat goes through there. So it's a potential way of educating your immune system, and then your immune system then educates the rest of your body. So it's very, very complicated though. So exactly how it works, nobody knows, but certainly, you know, the old expression, you are what you eat, is probably taking on a bit more relevance these days, because even the amount of fiber you take, because all the good bacteria love a high fiber diet. So it may be, you know, in the future that, and this is probably one of the things that's going to come in through artificial intelligence, is that before, you know, people start treatment, is that they'll have their microbiome profiled. And if it's found to be out of whack, you will be given either what's known as a crapule, which can be, you know, other people's good poo, turned into a tablet. So capsules, I thought that was quite funny. And you can use that to maybe optimize somebody's microbiome before you start any of your treatment to give you the best chance of responding. So this is sort of what I think might happen in, 10, 15 years time. And that way you can fine tune your chemotherapy, your immune system to reduce complications and get the best possible chance of the best result. Because it's going to be one of many factors, as well as doing all the genetics and all the tumor stuff. I think all of these microbes, because there's so many of them, and potentially because they're all modifiable and you can change them, I think it's, it's fascinating. But we just have to wait and see how much of it stands up to scrutiny. I think there's a lot of work to be done.
Yeah, it just depends on how much research goes into it, doesn't it? Like, it all depends on funding.
Well, yeah, absolutely. And, the way things have gone, the University of New South Wales has just had to sack 500 people. And the funding is just, it's just gone from being extremely hard to almost impossible now to get any money. So we often rely on, kind donations from charities and things to be able to do stuff, because otherwise you just can't. You've got all these ideas and material to do it. And we were fortunate, we got some money to do part of our endocrine study. We got some trial money from the university about 18 months ago, which is helping to do, because the sequencing to do all of that it's very expensive to do. So you can't do it without money, but we'll just have to see how it goes.
Yeah. I can remember at Relay for Life, someone explaining once that the funding mightn't go to, even if it doesn't go to staff, it might go to a machine that can process slides like thousands times faster than a human can. So it can speed up research so much. And I thought, yeah, you don't even, as a patient, you don't even think of that kind of thing. And why it's so important to donate to research when we can, because the processing the information is what is the hard part.
Yeah, absolutely. I mean, the technology also changes very quickly as well. So about every, 3 or 4 years, the technology will take a massive leap forward, and the speed and the complexity then moves on to the next level. So it allows you to do things that you couldn't previously do before, and it allows you to do things much faster and at much bigger scale. So you can look at what used to take. Well, even if you think about the Human Genome Project, which took cost of $1 or $10 billion, it took 10 years and about 50 different places all over the world. Now you can get the sequence of your old genome for under $1,000 in 24 hours in the space of 10 years. So it's ridiculous. So I can't imagine really what will happen next. It's just you just got to try and keep up with it, because it's mind blowing the amount of if you go into the literature to see what's the number of studies that are being performed, it's the rate of change and the amount of information is just absolutely massive.
I have a question, if that's okay.
Yeah.
Sure.
Yeah, go, Melissa.
Yeah, thank you. Apologies if everybody else caught this, but can I just go back to, so I'm having chemo and then I'll be having a mastectomy next year. So you said during the surgery, blue dye will be inserted and that'll show up which nodes are likely to have it spread to. And if it's in the sentinel node and tests positive for metastatic, which is what mine has, and plus another one. So then did you say that they would remove all the nodes then? Did I catch that right?
Well, it actually depends. It's okay. So that's actually changed a lot in the last 5 years. So 10 years ago, everybody, didn't matter whether your axilla was involved or not. They used to start off in the old days, everybody had an axillary dissection. Then when sentinel nodes appeared, if the sentinel node was positive during the operation, then they would go on and then do an axillary clearance. Didn't matter how big the deposit was in the sentinel node. Now that's again changed. So even if you've got a sentinel node, if it's just a small deposit, which is less than 1 or 2 millimeters, then often they will just leave it the other lymph nodes alone. If it's bigger than a couple of millimeters, and it's if the axilla actually, when the surgeon's examining the axilla, can feel it as abnormal, then you may well go on and decide to do a complete clearance. So the circumstances around who gets a complete axillary dissection now are less well defined, and there's more decision making now to try and avoid doing a dissection wherever possible, just to avoid the complications. So I couldn't say what will happen in your particular case. If it's you know, when you have your surgery, it may well be that they'll take a small sample of nodes. If they know that 1 or 2 are involved, they may take a little bit more than that, just to see. Because again, sampling the axilla, if you're having chemo, it's important to check on those deposits in the axilla to make sure that they've disappeared as well. So we have to be absolutely sure that they've sampled the nodes which they were trying to get out. So that can be quite a bit of work involved for us in trying to make sure that those all get identified accurately, so that you can gauge the response not only in the breast but also in the deposits in the axilla.
Okay, thank you. Yeah.
Yeah. So what you're saying, even an axillary dissection can vary a lot. Is that what you're saying?
Absolutely. I'd say most people now don't have axillary dissections. They will have 3, you know, sentinel nodes, and even if 1 or 2 nodes are positive, they still won't go back.
Okay, that's good. So what no tool of the day, but at least it's not just a blanket clearance. Yeah.
Yeah, absolutely. So it's much better for the patients. Definitely.
Yeah. Thank you.
Maureen.
Wait a minute.
You're on mute.
To unmute.
Might be good to unmute everybody, Kristen.
Sorry. Yeah, sorry. Just in regard, I had my lumpectomy 2 years ago, coming up 2 years, and my surgeon knew it was in the from the biopsy that it was in the sentinel node.
Yeah.
And he told me before my surgery that he was going to do an axillary clearance of about 15 lymph nodes.
Yeah.
And it was, I think it was only about 1 mil or 1.5 mil in the sentinel node.
Yeah.
So I was just surprised that he took like 15. I thought that they would have, and the biopsy then come back that it was only in the 1 node.
Yeah, look, the practice does vary depending on surgeons, and dependent on the other sort of histological features of your tumor as well. So
yes,
it depends on a lot of things. So the surgeons often, and if they've had imaging of your axilla, there may well have been other nodes which he thought might have been enlarged and might have been worried about.
Okay, because
So,
I had triple negative, so it is the invasive aggressive one. Just also in regard to that,
yep.
Can you actually tell from the pathology or estimate if by the size of the tumour and the type, if it is a grade 3, how long that you've had that cancer for? Like if you've just gone for a 2-yearly mammogram and it's shown up, is there any way of estimating approximately how long that cancer was there?
Yeah, look, there's no certain way. The trouble with triple negative cancers, so triple negative cancers are often the ones which are the tumors which pop up between mammographic screens. So they're called interval cancers. Now, the reason that happens is because they often just appear out of nowhere and can grow rapidly within a period of a few months. So we've seen tumors as big as 5 centimeters or so, which have appeared within the space of 3 months, and in people who've been for mammography, and even people who, have got a family history of breast cancer, have been for MRIs and had an MRI yearly, and in between the yearly MRI, there was nothing, and then in 6 months, they've developed a 5-centimeter tumor.
Yes.
So
mine was only 1.5 centimeters.
Yeah, so that's still small. So relatively speaking, and they tend, because they're all grade 3, they grow quickly, but they usually, they'll usually take 6 months to a year before they're actually, pea-sized and palpable. And certainly the ones which are slower growing and ER positive can take, probably, 5 or 10 years before they become noticeable. And that's why most of them are impalpable, and the slow growing ones get picked up by breast screening. But the fast growing triple negative ones, it's hard to say when they start and why they start. Really, nobody really knows. They're all different, because some of them you can see are really dividing really rapidly, and others, it's not quite as much as that. So there's just a huge spectrum, so it's difficult to put a finger on it, but it's certainly months or years is kind of the average.
I was just going to say also in regard to that, because I'm coming up for 2-year scans,
Yeah.
that's only going to be like an ultrasound and mammogram.
Yeah.
Also, because of the higher risk of it coming back with the triple negative in the first 5 years.
Yeah.
Is it worthwhile to have a PET scan done after this? Do they show up? It has to be at a certain stage before a PET scan will pick up another tumour, or if it's metastasized or anything like that?
Yeah, look, I don't know. I mean, I don't really get involved with ordering the PET scans. That's all the oncologists who decide to do that. And I don't really know what the reasoning of the indications.
Well, she said it was up to me.
Oh, I see.
If I have it or not. But I didn't know whether, by having it, does it pick it up? If you're not going for a mammogram for another 2 years, and a mammogram is really only showing up that certain area of the breasts and that.
Yeah, look, it's still, I mean, I would be guided by, certainly get the mammogram and the ultrasound done first, and see if there's anything there that's of any concern. If it's clear, hopefully, and then you've got 2 years to wait. I mean, I think I would just discuss it with your oncologist and decide if you're worried about it and you think you'd like to know, and just that a little bit of extra reassurance that there's nothing going on. But PET scans can pick up other things as well that aren't necessarily cancer. Okay. So it's the same as MRI. MRI was thought to be the best way to pick up cancer, but it picks up so many other things as well that turn out to be nothing. So a lot of surgeons are kind of don't go straight to MRI unless you've got a good reason, because they've been using mammography, and there's a new technique in mammography now, which is the one where they inject contrast now as well. So that you do a little injection of contrast and then do the mammogram, and that gives really good resolution, which is better than standard mammography. So that's kind of appeared in the last couple of years as well, which is something that some people get as well. And ultrasound it can pick up densities and lumps and bumps, but once you've had surgery as well, then you can have abnormalities just in the area of the bed of the excision, and that's where you really need to do a comparison of sequential films so that the radiologist can see what was there before. So I would just do what you had planned and then discuss it with your oncologist. And if it's playing on your mind, just to let her know. And if you can get it done and you want to get it done, then by all means. I'm not sure about the costs involved of getting PET scans.
Apparently they're covered now. It's just a new thing. They are covered.
Oh, really?
Breast cancer.
Oh, okay.
Yeah. My oncologist said it's only been recently. That,
okay. Yeah, because they used to be really expensive as well. Yeah. Yes. And there was always a big delay because there wasn't a PET machine, but there's now a PET machine in most radiology practices have them, so the wait probably wouldn't be too bad.
And also, just on the pathology report, what does the KI reading mean? Okay,
so that was in the images I showed you of those brown dots for the neoadjuvant study. The Ki-67 is a marker of cell division and growth. So the more brown dots means the more rapidly the tumor is dividing. So we sort of estimate that by looking at the tumor slides and sort of estimate the percentage of cells which look as if they're stained brown, and that we give that a score, usually, when sort of 5, 10, 15, 20, 50, 60, that sort of thing, in terms of the percentage of tumor cells which are dividing. So it tends to kind of correspond with tumor grade. So grade 3 tend to be sort of 20% and above. If you're sort of grade 1 or 2, it can be, less than 20 and often down as low as 5%. And these are the things that actually change. So when we measure this on our neoadjuvant hormone study, we like to see people starting up at 20 or 30% and actually get all the way down to less than 5%, which is a really good response. So these are the sort of numbers that we look for when we're checking the patient's biopsies.
So the higher the reading, the more faster it's progressing, is it?
Yeah, that's the faster it's growing, essentially.
Thank you.
Anybody else
Maureen,
got any questions at all?
I'll just say, Maureen, I had a PET scan at Miranda like about a week after I was diagnosed, and it was fully covered by Medicare.
Yes.
Wow, that's
Yeah.
great.
Yeah, that's what the oncologist said.
Yeah.
And
it was I was in within a week. So.
All right, great.
Yeah.
I've got one quick question. It's the word popped up in one of your slides, which was apocrine or apocrine.
Yeah.
Just wondering what the significance of that is, because in my initial pathology report, it mentioned that it was apocrine in appearance, and I never really understood if that was significant.
Yeah, good spot there.
Yeah.
So apocrine is a reference to a type of change that you can see in the normal breast. So apocrine is a type of secretion that you can get not only in the breast. So you've got apocrine sweat glands all around your body, particularly under your armpit and your axilla.
Mm-hmm.
And it's a type of way that your body makes secretions. Because your breast is like a modified specialized gland, which is related to a sweat gland, you can see changes in breast tumors, which actually look like things that you get in other glands, like salivary gland tumors, because they're all sort of embryologically quite similar. So an apocrine change is a type of cell which is very pink and granular.
Mm-hmm.
And that's what you see in normal apocrine sweat glands. But the tumors which look apocrine just look very pink. Now, although they're called apocrine, from a sort of pathology point of view, they often tend to be either triple negative or they can be positive for androgen receptors as well. So that can often prove helpful for treatment, because for those ones which are triple negative, to add onto chemotherapy, they can actually use androgen receptors as a blockade instead of using estrogen receptor treatment. So they're not very common. You see, a handful of these every year, and you really have to stain for them as well. So we can do androgen receptor stains. Occasionally, the apocrine ones can be HER2 positive as well. So they're kind of So they're usually RPR negative, HER2 occasionally positive, and androgen receptor usually positive as well. So they're kind of mixed bunch, really.
All right, thank you.
Hey.
A lot of big words.
Yeah, I'm sorry, darling.
A lot of big words in there, hard to understand. Have you got any questions? What are you going to say, Di?
I was just going to say I had breast cancer the first time 12 years ago, and which was calcification. Then last year I got it again in the other breast, which was also calcification.
Right.
The first time, was estrogen negative, HER2 positive, estrogen negative, and and then this time it was the opposite. So I went on to tamoxifen because the estrogen, even though I'm well and truly past menopause, I didn't. Within 3 weeks, I had a deep vein thrombosis, and I have varicose veins in my legs, and I had one that was one whole clot from my groin to my ankle.
Wow.
So I had to go off it, and of course, and on blood thinners and the whole thing to, disperse it as quickly as possible.
Wow.
So I can't go on tamoxifen. But now that you were saying about the possible that estrogen gets reabsorbed maybe a little bit, but our body doesn't excrete, am I more at risk now because I can't take the tamoxifen?
Oh, difficult question. I don't think you'd be any risk.
Yeah, I'm good at that.
Yeah. Yeah, look, I think your oncologist would know more about the drug side of it than I do. I mean, your estrogen metabolism is pretty well keyed up for your individual. Sort of everybody's the same, and you've got your own the way that it's normally absorbed, because that's what it does normally anyway. It's not like it's abnormal. That's what it does. It goes round in a circuit, and it's just the raising the possibility that some of these bugs might be playing around with it. But I don't think the tamoxifen itself would change any of that. The tamoxifen is really just blocking what's happening on the tumor cell surface. So I presume there's nothing else that they can give you because of the deep vein thrombosis, because that in itself is, it would be a concern. You wouldn't really want to have any risk factors for that.
No.
So you would just have to discuss it with your oncologist again, I think, and see what they thought. Because I'm not really involved in all the complications side of it. I just kind of provide the information for the oncologist so that they can deal with the difficult questions like you're asking me there.
I'm sure Di would have done it all under supervision, wouldn't?
Oh, definitely. Yeah, definitely. It was no problem at all. And but there was no thought of me going on anything else. I think my reaction was so extreme that I think they sort of thought, whoa, I think we better keep away. I think I've got a better chance of dying of a clot than I have dying of breast cancer. So,
and that's what you're going to do, weigh out the risk.
Yeah, that's right, exactly.
Absolutely.
We took the better of the both options, I think.
Yeah, definitely.
Yeah.
I've got a question.
Yeah.
Yeah, I had two tumors in my left breast. I had a lumpectomy. One tumor was like 1.3 and the other one was 1.5, but they were kind of next to each other. And I think that there was sort of like, it was explained to me that they kind of were branched together by branches. Would one tumor have branched out and caused the other tumor, or would they have grown independently and then kind of like, how does I don't know.
Yeah, I know what you're saying. It's kind of confusing. So often we get sent specimens where the surgeon will say, oh, there's two tumors in the breast. And then when we actually dissect it and take the sections, we can actually see that it's actually just one tumor. It's just the way that it's growing.
Yeah.
Because often they can be dumbbell shaped. So you've got, two lumps that you can feel. And then in the middle, there's a little stringy bit of tumor in the middle that joins them both together.
Okay.
So the rules that we use are that they're to be classified as two different tumors, they've got to be distinct, and there's got to be a gap of 5 millimeters in the middle where there's no cancer. Now, sometimes you can have two tumors that are linked with a little bit of cancer or a little bit of DCIS, which might have been growing there originally, and then it's just grown individually as two separate tumors, but they would have grown individually. And then probably over time, if you hadn't detected them, they just would have merged into one.
Right.
So it just depends on the time course and the rate of growth and where they actually are geographically in the breast. So it's not uncommon to find a second tumor. I'd say probably in about 30% of cases that we cut up, and we'll find a second tumor that the surgeon didn't know was there.
Yeah.
Because we go through it in such detail that it's even in radiology didn't pick it up, because it'd be very small, a little satellite focus, as we call it, around the edge of the main tumor. Okay,
yeah, that makes sense. Also, my margins were like millimeters, clear by millimeters. Is that something to worry about?
No, not really. Margins is one of these funny things, because that's probably what takes up the most discussion time when we meet at the MDT meeting.
Yeah.
So we usually go through all the pathology, and I'll bring the slides along for all the cases that the surgeons are worried about having close margins, because it can come down to a fraction of a millimeter. Now, something you have to realize as well is that there is a bit of artifact in the way that the specimens are assessed, because when you're actually dealing with a living patient, the tissue is actually stretched out spatially compared to when you cut it out and you put it in a bucket. So when you put it in a bucket, you get what's known as the pancake effect, because the tissue just from gravity just goes and it flattens out. So everything seems much closer than it actually is in reality.
Okay.
But a lot of studies that have actually measured the distance of where the cancer is to the ink, and as long as you basically got about a millimeter, in some places even less, you can actually do as well as having a massive clearance.
Okay.
And the trouble is, if you go and take more tissue and take out more stuff to get wider margins, it doesn't actually mean that you got less chance of the tumor not coming back. And you reduce the more tissue you take out, you get a worse cosmetic result as well. So all of this has been studied for the last 20 or 30 years in big trials. And basically, if you get a clearance with about a millimeter or so of clear tissue, and all the pathology is done nicely and well, and most people get radiotherapy, which adds significantly to reducing recurrence, then most people will do well. And there's only a few cases who will have a recurrence. So, I wouldn't worry about that at all. I think, the treatments that you get as adjuvant treatments with chemo and endo and all the radiotherapy, anything that may be microscopic usually gets mopped up.
Yep.
There is a tendency now, again, to do less in the way of re-excisions because of all this extra treatment. A lot of people are now, in certain studies, we're even going back to saying, if the tumor is, even if it's on the ink, we should think about going back. But even then, you don't always have to. So this is a big discussion that goes on, and it depends not only just what margin it is as well, because some margins are less important than others. So, so I think it's fine.
Great, thank you.
I think that's very, very reassuring to actually hear from someone who's actually there about how it's all analysed and the margin stuff, and to hear and see those team meetings. I know even from when it was mentioned at another Zoom we had, I know a few women sort of said, wow, they didn't realise that so many people actually help make the decision. So it makes them feel very well cared for, and that there's no second judging, like it's multiple people involved in the decision. Like I think we're so lucky to have that available, but even to know about it, because I think most people don't realise how much goes into involving making those decisions. Women think it's they're making the choice, but we've got so much help. It's fantastic.
Well, yeah, it's a big advance. I think the MDT meetings have been around for the last 20 odd years, so it certainly improves the outcomes for patients. And I think when you get different opinions, I mean, you do get a variation of opinion on treatments, but that's to be expected. But everybody gets a discussion. So, Moira will be there, and we'll go through, every 2 weeks, we'll go through another 40 patients. So everybody gets a discussion, everybody, gets to put their hand in. And then for the tricky ones, I mean, I don't have to contribute to all of these, because most of them, the decisions can be made on the pathology report where it is. But if someone's got something unusual, or there's something which isn't clear, or the margins are close, then I'll come up with the slides, and we'll actually show them at the meeting, and I'll show the slides to everybody so you can actually see what the problem looks like. And then often it becomes clearer to everybody, because sometimes, you're writing a report in English and you're trying to describe something which is a visual issue. And often it's easier for me just to show the slides than try and describe it in words. And then you're trying to, give everybody an impression of how much disease there is. It's easy just to put it up and say, well, this is what it looks like. There's the edge, there's the ink, there's the margins. What do you want to do about it? Do you think you want to go back? Are you happy? So everybody just chips in, and, we work it out.
Yeah, it's such complex, and like you said, it's not just the pathology, all the other stuff that's involved in it.
Yeah, it's down to the individual, so it's very personalized as well, because not everybody needs an operation, or not everybody would be fit for an operation as well. Once you get into some of the older patients who maybe aren't quite up to having more surgery for a number of different reasons, so it's all tailor-made.
Yeah, that still baffles me when I hear of 80-year-olds having lumpectomies. You kind of think, why?
Yeah, absolutely.
Why would but it still happens. I've met lots of people, 80-year-olds, 90-year-olds having lumpectomies and chemo.
Yeah, absolutely.
Maybe not chemo so much, Kristen, anymore.
I think there was one, Lily told me she was fitting one for a bra or a prosthesis, and she was like, why would you put an old lady through that? It just makes sense.
Well, I guess that's what Ewan's saying too. We look at all their other health history and how fit or unfit they are for other treatments. So
maybe this poor lady wasn't lucky enough to live in the Shire.
Oh, possibly. All right, I'll just quickly ask, has anyone else got any burning question for Ewan? Because I am aware of time, and it's probably time that we let him go. And no, nobody else has got a burning question.
Oh, just one more. I was just going to ask, when you mentioned earlier, I thought everyone that had triple negative cancer had to have chemotherapy, but you said some people don't, which sort of amazed me.
Oh, no, well, yeah, it depends.
There's no other treatment. There's no other specific treatment for it.
Yeah, well, that's what I mean. Some triple negative cancers don't need chemotherapy because they just grow locally and they don't tend to spread. So they're a special group of triple negative cancers, and some of those are some of the ones which are called metaplastic cancers. They're called metaplastic because they don't actually look like normal cancers. They look more like soft tissue tumors, but they're kind of cancer masquerading as a sort of different form. So they try and trick the pathologist by looking like something else. So those ones don't need to have chemotherapy. And there are a whole group of tumors which actually are triple negative, but they actually look more like tumors that you get in salivary glands as well. So they're classified as triple negative, but again, those ones don't tend to spread either. So they're much less common than your usual type of triple negatives, which do need chemotherapy. But this is these are the sort of little things that we bring out at the MDT, because sometimes somebody hasn't read the report properly and they'll say, but you said it was triple negative, I'm going to give this woman chemotherapy. And I'll say, well, no, that's not appropriate here, because this one doesn't need chemotherapy. It just needs to be completely cut out and maybe radiotherapy, but doesn't need chemo. So you're going to put the patient through unnecessary poisoning for no gain.
So I think you had a slide in there, didn't you? And I thought that was a good point.
Yeah, that's right.
There's different types of triple negatives.
Yeah, so there's different types of everything. So you've got to, that's where all the oncologists have to know the pathology. They have to understand what we're trying to tell them. And if they don't, then they need to put their hand up and say, I don't know what you mean. Please explain, in which case I will. So I'm going to keep them right. I mean, they do a good job. So most of the time I don't have to say anything. But if they want an explanation, then I can give them one.
So I think that my tumour in my lymph node from memory, I've got triple negative. And I think it said that it was possibly metaplastic in appearance. I haven't got the report with me.
Yeah.
But if I've also got a 4 centimetre tumour in my breast, then I probably would need chemotherapy anyway, which I'm into.
Yeah, I would think so. Yeah. So the metaplastic ones are usually, tend to be grade 3 and need chemotherapy. So and most of those now I tend to go for neoadjuvant chemo as well. I don't know if you had neoadjuvant.
That's what I'm having. Yeah.
So the trend in management now for most triple negatives and HER2 positives is to do neoadjuvant to get the extra information about the treatment response in the resection specimen after a few months of treatment. Because you do get extra information about the number of cells that are left or whether it's completely gone. So some people have a complete response, some people have a little bit of response, some people have no response. So it's again varied, but that's again part of what we do, and looking at these specimens very carefully is another important part of our job, because it's actually becomes when the chemo has actually worked very well. Sometimes we go through the specimen and we take 50 or 60 pieces of tissue and we can't find anything. And we don't even know if there's been, a tumor there to start off with. So sometimes it just completely disappears, which is great. But also at the same time, we want to find evidence to make sure that we've sampled the right bit of the breast, because it can be very tricky to find. So often they'll put in a little clip as well. I don't know if you might have had, you put clips into where the tumor is so that when it shrivels away, that's where the pathologist needs to go looking. And we can x-ray the specimen and find the clip and then section that whole area out and take a whole chunk of tissue out and look at it.
Yeah. So I was just going to, do all grade 3 ones need chemotherapy? All grade 3?
Well, mostly probably. I mean, if you're ER positive in grade 3 and of a certain size, and depending what your lymph nodes are, it's kind of dependent on whether you get endocrine therapy and chemotherapy. If you're triple negative or HER2 positive, then usually you'll get chemo and then extra Herceptin or another sort of Herceptin-like drug as well. But the decisions, again, are they're not always straightforward. There's a lot of other things they'll take into account as well, like comorbidities, other illnesses, and, whether your heart's working properly, things like that. So it's not a black and white decision, but, you've got to treat usually these higher grade tumors, especially if you don't have any targeted treatments like an ER or Herceptin, then chemotherapy is going to be up there for consideration.
Thank you.
Okay, well, I think we might let Ewan go now. I was going to say go home, but he already is.
I'm already there. Going to have a cup of tea because my voice is starting to dry up a bit.
You deserve it. You deserve it.
Tea and a throat guard.
All right, well, thanks very much for having me again.
Thank you.
Thank you.
Thank you so much for your time, Ewan. And
no problem.
Also, thank your family for giving you up for an hour.
So I think they're glad to get rid of me, I think.
No, thank you very much.
Thanks.
Okay.
Thank
Good night,
you.
everybody.
Thank you.
Okay. See you next time.
Good
Bye.
night.
Night.
Thank you.
Bye.
Wow.
Yeah.
Wow's the word, isn't it? Yeah.
He
That
was
was
so
great.
great. We got him last
Oh,
night
so
too,
good.
and
Yeah.
he's just so great.
Did you have him was it last year you had him? Because I
Yeah.
didn't,
Yeah, when we're at
wasn't at that
tradies.
one.
Yeah.
Yeah. And he was there in person. Yeah, he was there in person because we could
Yeah.
see each other then.
Mm.
We could be in the same room
It was
then.
pre-COVID.
Yeah.
As I was saying to some that came on early,
Yeah, sorry, I was late. I thought it was
slap your wrist.
7:30.
I was at tradies for work last Tuesday working, and I bumped into Tina, who's the events person there, and it looks like we're going to be able to go back from February.
Oh, great.
Great.
Yeah.
As long as nothing happens more with COVID. It was really good. I got to talk to her as far as why we like having the Darawal room compared to the boardroom, that we've got room to split up into groups and that. And so with her understanding why it looks like we've got Darawal room, I've just got to put the form in so that we don't have to pay for next year. But with the numbers that we can have, I think it was up to 29 in that room, which covers us. So December will be, we'll send out an email, but December we're going to have a picnic, looks like at Miranda, for dinner. And then we don't meet in January, but we do have Camellia Gardens. But then we're back on February, and Kristen, Moira and I and the other breast care nurses will, meet and talk about, what we're going to do and what the topics will be. So if you've got anything that you would love us to focus on 1 month, just send Kristen or myself an email, and we'll add that to the list when we talk to the girls about it. But yeah, we're here to support you, and some are down the track where they're wanting to, still be part of the group and help others. So that's what it's all about. So yeah, it's really good that Shamila's come on tonight.
Thank you so much for inviting me. Thank you.
No, we only met yesterday through me being in hospital. She was my nurse. So yeah, it was incredible just to touch base there. And for you other ladies, just for those that are still having treatment, just keep going. Remember, we're here, if you need to talk at all.
Hopefully Melissa and Lisa, you got your questions answered.
Thank you. It was really great.
Things.
It was great seeing all the slides and seeing what it actually looks like, what that tumor looked like was inside you,
Yeah, what he's going to do, he'll be sending through to us his PowerPoint slideshow, and we'll then email it out to the group.
Thank you.
They're happy for us to do that. So because it's hard to take everything in.
His presentation from last year is actually on the Facebook page as JPEGs. I think it was I can't remember off the top of my head, but sometime last year I converted them all to JPEGs, so there was a few overlaps. So if you want even more information, it is there on the Facebook page.
I just want to ask about what you were talking about earlier about Alison becoming a McGrath nurse. Wasn't she always a McGrath nurse?
Oh. No. There's been a bit of a change. Kim is funded through McGrath, and Kim is predominantly over at Sutherland Hospital, but also across at St George. And Alison was fully funded through St George Public Hospital, but she has now become a McGrath metastatic breast care nurse. So it was a new position that was created earlier this year, and she applied and was the successful applicant. So she now covers and provides care for metastatic breast cancer patients, which is a very needed position. And it was an area that was not as well catered for as the early breast cancer women. So, and McGrath is concentrating a lot more now on providing metastatic breast care nurses as well as early breast cancer nurses. So
Which hospital's that?
well, she's covering St George public and private.
Oh, okay.
So she works across both sites, and Kim is still over at Sutherland Hospital, and she's doing the metastatic patients over at Sutherland as well as the early breast cancer patients. So
Laura, are you just at St George on your own now, or?
I'm our funding is all a little bit tricky. I'm employed by New South Wales Health and under the St George Hospital public banner, but St George Private actually funds my position because they have a contract with St George Public to provide a service to the private. So I am basically down at the private hospital every day as the breast care nurse to the patients who have surgery or treatment at the private hospital. And then
that's confusing.
It's very confusing.
And it changes every few years. I know since I met Alison, 14 years ago, different funding. You realise not all nurses are McGrath nurses. There's lots of funding, and they can be part funded for 2 days here, and then part they might work. It looks like the same job, but actually they're doing like a different job another 2 days, or another day they're in oncology. It's very confusing.
Yeah, and then we've just had a new member join our team. Her name is Laura, and because for those of you that know or knew Rosemary worked 2 days a week in the breast care nurse position, and then when she retired, the public hospital actually changed her position and made it a breast care nurse coordinator position. So basically that position works predominantly down in the clinics in the cancer care centre. So that's basically a 5 day a fortnight, position. And Laura Gibbons was the successful applicant and took up that position probably about 5 or 6 weeks ago. So for those of you going to the clinics on a Tuesday, Wednesday or Thursday to see one of the medical oncologists or radiation oncologists, you may well meet Laura in your travels. So
actually a McGrath one at St George then?
No, she's funded through St George Public Hospital. So she's not McGrath funded. It comes from St George Public Hospital's purse, so to speak.
So she's called a coordinator. She's doing paperwork, or she's actually breast care nurse?
No. She's not what we all do paperwork, believe me. But
I'm hoping she does the paperwork for you.
Oh no, I wish no. But she covers the patients who are attending the clinic in the cancer care centre. So she does a lot of when we say coordinator, it's like coordination, basically.
Of the patient. Okay, not coordinating you. Coordinating.
She can coordinate me if she wants to.
Good luck.
I need a bit of coordinating sometimes. But
and I guess that allows Alison to specialise in the metas. Yeah.
And Laura is also seeing the surgical patients at the public. So look, it's still not enough, I'd have to say. It's still not enough nursing staff hours probably for the amount of workload and the amount of patients that we're seeing. But we're just trying to work with what we've got and do the best we can and provide the best service we can for you ladies. So
just spread yourself over the, what is it?
Correct.
200 or 400 new
500.
500.
Well, yeah, we're seeing probably about 500 plus patients a year. So
what about people who have treatment outside of the hospital at private clinics?
Yeah,
so we access, Alison?
Yeah, of course you can. You can access whoever is appropriate for you. If you're a secondary breast cancer patient or metastatic breast cancer patient, you can absolutely contact Alison. Absolutely. And for those ladies who might be having their treatment, who might have their surgery, say at St George Private, but then go to a private facility for their chemotherapy, like Southside at Miranda.
Yeah, that's right. Yeah.
Yeah, you can still access us. We can't visit you at that facility,
No,
but because we don't have a contract with Southside, but you can certainly access us, or predominantly if you were having treatment at Southside and you live, say, in the Shire, then I would probably suggest that you contact Kim at Sutherland Hospital, because it's a bit more local for you, but you can still access our service, most definitely.
because I'm still coming up to St George for brain MRIs and stuff.
Yeah, and you could certainly make contact with Alison, and then, you know, you could make an appointment to see her independently, and I'm sure she'd be happy to catch up with you, provide you with information and her contact details.
Okay.
Yeah, which is all on the McGrath page, because she's a McGrath nurse. That
yes,
is on the Find a Nurse on the. They have a very good web page for.
Yeah, they do. They do.
Contact details.
Yeah.
Myra, what's the reason for people to go, say, to Southside rather than stay within the hospital for radiation or chemo?
So Southside at this point don't have a radiation oncology service. So they would have to come across to either St George, or there's 2 private radiation oncology centres. So one is Genesis Care at Hurstville, which is under the Waratah private hospital banner. And there's also another service at Revesby under the Icon banner. So look, it may be.
Is there a reason for that?
Convenience, possibly.
Okay.
It might be.
I can give an example. Sorry.
Me too.
Yeah, I was diagnosed middle of September, and my oncologist, who I saw at the public hospital at Sutherland, she recommended that I go private if I had private insurance, which I do, because I got in to start chemo like 10 days after diagnosis, less than a week after I saw her. I've got a 4-centimetre tumour in the breast, which is aggressive, triple negative, and a 3-centimetre one in the lymph node. And she said she would urge me to get started straight away on chemo.
Yeah.
And so that, whereas I would have had to wait 2 to 3 weeks, and definitely for my mental health.
Yes. You want to start as soon as possible.
I wanted to get started. I would have started the next day. So that's why I chose.
Yeah.
And the private health insurance covers the full cost of the chemo. Yes, I pay. It also means I see my oncologist each time I have an appointment.
Yeah, versus possibly your oncologist, or possibly the registrar or advanced training. Yeah,
that's right. So for me, that was the choice I made. Yeah, but I think yes, I will have to go to the public hospital for radiation next year.
Yeah, and that's fine because your medical oncologist is across all those sites. So yeah, and for some women it's convenience as well, because they want to stay in the private system, and they want to stay closer to home, so they want to go to Southside because they live in the Shire versus coming across to St George.
I mean, I live in Yarra Bay, and Southside is literally 5 minutes away.
Absolutely, just up the road.
I'm also very anxious and prone to fainting, so it's a much less confronting place for me to be, and huge benefit, parking on site.
The parking underneath, you don't have to worry about parking, and it was really good.
Security guy waves you in.
That's probably good enough reason on its own.
Yeah, that's right. So it's worth those years of paying the private health insurance. So
exactly, yes.
And then,
I guess one other thing is.
So I also thought. Sorry.
No, Melissa, you're right. I was just going to say one other thing is that both the private facilities, Southside and St George Private, also offer scalp cooling, which isn't yet available in the public hospital.
I did that.
George. Yeah.
I was offered that, but I get migraines, so it was not recommended.
Brain freeze.
Yeah.
Did you find
it
successful? I had it, but still lost a lot of hair with it.
Yeah, and it does vary from woman to woman.
Yeah, it was fantastic. My hair thinned.
Yeah,
but it didn't all fall out.
No, mine didn't either. And it grew back very quickly after I finished.
Yeah.
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 Moira,
Yeah.
as a nurse, do you ever try it? Have you ever tried it?
I have. When St George Private first got their scalp cooling machine, Alison and I went down and we put it on.
So you did experience it. That's a good idea.
We did. We put it on. We didn't partake of the chemo, but
Good choice.
we did put the scalp cooling on, and we sort of sat there with it for the first 20-25 minutes or so, which is often the bit which is the coldest, so we've been told, and then once you acclimatise, it's not quite as uncomfortable. But correct me if I'm wrong.
No, you're correct. I found after the first 15 minutes, you just get used to it. It's that initial 15 minutes that feels really cold.
And and I also used to take a couple of Panadols about an hour before I started it.
Yeah.
But it does make the treatment a whole lot longer.
Yeah,
because
that's the thing.
they leave it on for about 3/4 of an hour, maybe. I don't know. Correct me if I'm wrong.
No,
afterwards.
that's correct.
It's about another hour after the chemo finishes.
Yeah. So by the end of it, I was
hours.
hours.
It's a lot
hours
longer time. It's a lot
I
longer time.
actually used to fall asleep. I'd have people. I'd always take somebody, and they'd say to me, "Do you want to go? Do you want to just close your eyes?" And I go, "Yeah, that'd be great." And so I just lay back and have a little sleep by the end of it. But I used to go to Southside Cancer Care, and I always had a girlfriend or a family member with me.
And can't take anyone now. Yeah. You can't take anyone now because of COVID.
COVID.
I know.
Yeah.
So you can't have anyone at all, can you? Not at all.
No.
And that's the same to the public and the private? Is that the same?
Yeah.
COVID,
Yeah.
At the public hospital, they've now, as an inpatient at St George Public, we've just had an email saying that they are allowing 2 visitors, but in the outpatient settings, it's still no, 1 or 0, depending on the area. So it's getting slightly better, but it's still nothing like it was pre-COVID. Yeah.
I used to when I used to take a friend with me, so my treatment was about 9:30, and we'd get out about lunchtime, and then we'd go over to Miranda Hotel, and I'd have a big steak and steamed vegetables and everything straight after it. I'd be like, "Yep, come on, let's go and have a big meal," and sometimes I'd have a glass of wine afterwards, but. Yeah.
Harry, la, la, la. Don't want to hear you.
I used to feel really nauseated as soon as I got home. I couldn't.
No. This was the not the 4 really bad ones, like the first ones. Yeah, the 12 afterwards.
The Taxol, yeah.
Yeah.
Taxol was a lot better.
Oh, totally. Yeah.
Question, can I take a screenshot?
Yeah.
I'll go. Ready? Yeah. 1, 2, 3. Cool. Thank you.
Thank you.
Now, does any can I put that? Does anyone want that? Put your hand up if you want me to blur your face if I put that on a public page. Blue Bronwyn? No one else? Everyone else okay? Everyone's told their
question, Moira.
Soft focus would be all right. Soft focus is okay, but don't blur it. Soft focus for me, especially.
Oh, you must be out of your skin not travelling. Your holidays.
Yeah, I must admit, it has been hard. Yes, but I'm all booked to go to Adelaide for Christmas. So
nice.
Yeah, really good. Travelling business class to keep me as COVID free as I can. That's not really the reason, but it's a good enough excuse.
Well, you haven't been anywhere this year. You haven't been able
No,
to tell
that's
us where
right.
you've
No,
been.
no.
We're missing your stories.
Yeah. No, we're hoping we can all spend Christmas. The Queenslanders are going to come to South Australia if they can get away, and we'll all be together
I'm
again.
frustrated with that Queensland Premier.
Yeah.
We can't see our grandchildren for a year. We can't.
No, well, I haven't either. No, not good.
It's terrible. It is terrible.
You can meet them in Byron Bay now.
Yes, apparently so.
Yeah.
We're going to Byron Bay in January for a week.
Fingers crossed. Yeah.
Oh, I hope so. I hope so.
Now, I know Lisa had a question.
Yeah, I've just got a quick question.
Sure.
When do you get your port out? I'm on my tomorrow's my second Taxol. So
Yay.
obviously I've got a long way to go. but yeah, when do you get your port out? Straight after the Taxol's finished, or do you leave it in for a while?
You can pretty much get it removed once you've been back and had your follow-up after you finish Taxol. Have a discussion with your medical oncologist, and usually they're reasonably happy for you to have it removed, fairly quickly, and particularly if you're having your radiation afterwards, and if it's anywhere close to your radiation field, they'll want it removed anyway. So
yeah, I think it tends to depend on the lady, where it is, what your doctor is, what your pathology was. Like if they're worried you might need more treatment, they might leave it in. So
yeah, I had mine out before my radiation started.
Okay.
Whereas I know there was another lady who got left in for like 12 months.
Mine two weeks after treatment finished, after the Taxol.
Yeah.
Okay.
And so that lady you were talking about, Kristen, may have had higher risk disease, and so the oncologist just wanted to leave it in for a little bit longer. But for most women, they have it removed fairly soon after they complete their treatment course of chemo. Yeah.
I just had mine taken out like 6 days ago. So that was just after I finished Herceptin, which is a couple of weeks ago. So it was fairly quick.
Yeah.
And it's much quicker than putting it in. Well, I don't know if it's the same, but I remember, it was it weren't even anaesthesised. It was just like rip it out. So it was just a weird feeling.
I don't know. For me, the putting it in was actually a lot nicer than taking it out.
Oh, really?
Yeah, I think it depended a little bit on who did it. So different experience.
Yeah. Well, ladies, if there's no more questions for me, I might leave and let you girls continue.
I don't mind. I think we'll finish up if that's okay.
Yeah, and I think the other thing I don't think we mentioned, Community Gardens in a couple of weeks' time. What is it? The 21st of this month. If anyone wants to have a cup of tea at Community Gardens, third Saturday of the month at 9:30.
Yeah, so you'll get an email just reminding you for Community Gardens when it's coming up.
And the only other new thing is the separate to our group here, there's a separate email list for the lymphedema support group, and we've just organised a first ever Zoom meeting for the lymph. She was inspired by what we did last month. So she's got Leanne O'Brien from St George Public Hospital. She's going to talk about what's been happening in COVID world in the public hospital and lymphedema management. So if you're interested in lymphedema, let me know, because that's a separate email list that Anne Foster organises, and that's going to be on Tuesday, 17th of November.
And are we having another Zoom meeting before the Christmas party?
We'll have one more on the last one on the third Wednesday
18th
of this month.
On the 18th.
Yeah. Yep. On the 18th, and then we'll have.
It won't be a speaker. Just for those that want to touch base.
Yep. And then we'll have the picnic, which is going to be BYO. We're going to have 30, so I don't know what we'll do if more than 30 turn up. We'll have to plan that.
Well, I won't be making it because I'm down the gong.
No excuse.
I know, but it's through the week, and I'm just getting a bit tired. I'm getting tired of working.
That's understandable.
Oh my God.
Amen.
I'm not complaining. I mean, I love my job, but it's just, tiring.
Moira, sign off.
Okay. All right.
Ladies.
Have a good
Thank you.
Shabila, I'll give you a call tomorrow night.
Thank you very
Thank you
much
for organising that. Thank you.
Thank you
Pleasure.
so much.
No worries. Bye-bye.
Bye.
Bye.
Bye. Bye.
I have already had a picnic. Glenda, just so you know, I did have a picnic email from Beverly Weston. She wants to come, and Ophelia. So I'm not sure. Could bring a few people out of the woodwork.
Oh, good. Yep, no, that's fine.
And Beverly offered to be there early if we needed her.
Can I just ask you, I've got lots of bras and prosthesis over from my sale. I've sold everything I can. We still sending to overseas? No, nothing's happened. No, of course not. They'd be covered in COVID, wouldn't they? Okay, I'll talk to you later about it.
So I guess, so Maureen didn't want them back? I thought that was originally what she said.
No, well, no, you know, I've got more. I can put on, you know, a triple, double D extra XL, and I might set up a stall on the footpath. Actually, what do you think about that?
We've still got 500 kilos that we packed for Fiji still sitting in the warehouse down there. And we were trying to get them to Africa. Africa have sort of been trying to get tax rebates and all. It's been emails going back and forth every few months. Yeah, I did hear a little whisper. Some other bloke who works for a different charity for Fiji, Lily met him, and she's offered the stuff to him if he's willing to pay to ship it. And there's a rumor that he might be able to come up with the funding. And I checked out, they're called Resilient Women Fiji. They're all a legitimate organisation. He's like a high flyer. But yeah, of course, we'd have to go through it and like throw out any rotted boobs, and I'd have to redo, you know, my table with all the weights and stuff. So I don't know, I don't even think about it, but Lily's trying to go, I just want it finished, ended.
Yeah, well, I can understand that. So yeah, I've got bags of everything. So do you have any ideas of what I can do with it?
I know even Project Uplift have closed their donations for, because every time I get an inquiry, I say there's nowhere at the moment, because their Project Uplift were for a while taking stuff, brand new stuff, which that is. Support the Girls is the other option, which do have a drop-off place in Engadine. That's probably my only other idea, because it's brand new. Support the Girls. Take it. Ooh, that's a candle. The wax got to the bottom. Oh, the glass container just broke. Yeah, so that's my only other idea. Yeah, what sort of quantity is still left?
Oh, a fair bit. You know, we raised nearly $4,000.
And Maureen just
single-handedly, I might add.
Yeah, single-handedly. Because so and Maureen at one stage you wanted it back, and then so now she said just get rid of it, has she?
Yeah. I thought sure, I'll just
I'll just stall out the front of your house.
Exactly right. Yeah. Thanks for that. I mean, it came to my place because the woman that was donating it lived at Cronulla, and so therefore she, you know, I was the closest. It never got any further than my place. So I flogged it to every single person that I could possibly knew, including people that hadn't had breast cancer. So with the cozies and bras and things, you know, so I'm just basically left with what I'm left with now. As I said, it was just under 4,000, which was pretty good. That went to Helping Hands. No, where did? I don't remember where it went. Don't remember where it went.
Helping Hands. I guess the other thing, and maybe I'll look up, see if I can find your phone number to call, if I can find the New South Wales representative to Support the Girls, who's like, they're based in Queensland. I know they're still taking donations. I met the lady once. She came down to Sydney, met Lily and me at Hazelhurst.
Yeah,
because they do little fitting workshops for women who have like domestic violence or live on the streets. So they've got like a mobile van, and they package like care gifts, and they do bra fittings, because they say a lot of women on the streets don't have like toiletries and bra fittings. So they're often asking for larger sizes, but they don't take secondhand bras. They only like new pants. But I'm thinking, because all the stuff you've got is new, it probably would be relevant for them. And I know they were having what they call bra fairies in New South Wales. And I think there's one at Parramatta, and I know there's a shop in Engadine who's a drop-off spot. So I'll double check if that's still happening. And maybe if I find the phone number, get that to you if you want to. I can hand that over to you and you can give them a call, explain what it is.
And
whether
well, Elizabeth, you know, nobody, as I said, nobody's interested. Leanne just said, get rid of it.
Yeah.
Elizabeth, I can't do it to her because she's got enough going on and she's not well anyway. So, you know, I can't dump it on her, but she was going to take it because they were then going to start distributing it to people down in Wollongong.
Yeah.
You know, and do the next lot that I hadn't done. But then since COVID, you know, everything shut down. So
I know this group, they did shut down for a while, but I know they still are doing what they call like fitting days. So they might go to a rural town and they'll take product, and they were doing, I'll check if they've done any New South Wales ones, but they take like their van and they sort out all the bras. I get ideas from them when we've had us, and they take product. So if they're doing stuff if they're still doing stuff in New South Wales, if there's someone who's willing to store it, that's the problem, isn't it?
Yeah. That's the thing. You know, that's the thing.
Say what volume it is the hardest thing for you to explain on the phone, isn't it? So
it is hard. Yes, it is. Yeah. Because they're all different sizes and all different shapes and all different everything.
Yeah.
I've got most of it sort of catalogued, but then, you know, but then again, I have got a list. It's, you know, that might be something I can send to somebody and say, well, look, this is what I've got, you know.
But because you don't have email photos, and it's just that little bit harder. So I guess first thing we can start with, find your phone number, see if there's someone you could ring and say, I've got this, I'm in Sylvania. Is there anyone you know, reasonably nearby that wants it? Okay.
Okay, darling, thank you.
Shall do.
You take care.
You too, and I'll see you when I see you.
Yep.
Okay.
I'll
Let
see
you go.
tomorrow.
Okay. No.
Bye, darling. Bye.
Thanks.